So I'm Andrew Sharp. I'm a cardiologist from Dublin in Ireland. We have an all-star panel today. We've got Giuseppe from the Netherlands, Sophie Brewers, Stefan Togweiler, and Flavio Rubicchini. Lots of experience of both hypertension management and also renal denervation today. So we're going to talk about setting up a program. Renal denervation is now guideline approved by the European Society of Hypertension, the European Society of Cardiology, and it's now US FDA approved. So our American friends are really getting started with gusto. It's been around in Europe for a while, underwent a lull after some negative trial data. Now we've got 7 positive sham-controlled trials. So we've got plenty of data now. And so we're now going to talk on the mechanics of setting up trials and setting up programs. And see, that's I'm so used to saying setting up trials. But we're there now. We'll be able to now talk about ultrasound renal denervation and how to set up a program. So our first speaker up, he's going to get through the data. So we don't often, in the last 10 years, get to give you a talk title like this. So RDN works, the sham-controlled trial data that prove it. Finally.
Thank you, Andrew. So up to me to give you a short overview on the sham-controlled and non-sham-controlled data that's currently out there that actually demonstrated the efficacy of renal sympathetic denervation in the most rigorous trial setting, at least in as I've ever seen in my career. These are my disclosures. One introduction slide. So why is RDN important? Well, this is the number of patients that met ESC, ESH defined treatment goals in a tertiary academic setting, real life, just 2 years ago. So this is from the Erasmus Medical Center where I work, Rotterdam Academic Medical Institution, in which we found out that if you pick random patients with hypertension at our clinics and you give them an ABPM at the time they arrive at the outpatient clinic without telling them up front, 42% appears to be uncontrolled based on current standards, even in a tertiary academic setting. So this illustrates that in real life, there is a need for better blood pressure control, despite the fact that all these patients were on a median of 2 antihypertensive agents. So just as a very short introduction, to introduce you the concept of renal sympathetic denervation using ultrasound, which is a therapy that is percutaneous, balloon-based with a cylindrical transducer that emits ultrasound 360 degrees and with an ultrasound beam that is actually targeted to actually target the renal sympathetic nerves located 2 to 6 millimeters just outside of the renal artery wall. The generator is very small, so it allows you to do 2 to 3 ablations of merely 7 seconds, in which the system automatically detects the balloon size, which is 1-to-1 size to the renal artery, in order to define the optimal algorithm to define the treatment depth. And then there is where the yellow is in the balloon cooling, which prevents renal artery damage induced by the catheter. So we had a very safe and efficacious system, at least in the way it was designed, but that now also is confirmed in a clinical trial pipeline that is substantial and has been developed in the past decades. Perhaps most importantly are 3 successfully performed randomized sham-controlled trials, being Radiance Solo in patients off-med, in Radiance Trio in patients on a triple standardized combination pill, and Radiance 2 pivotal, also done in patients taken off medication, a program that is now substantiated by 3 active trials in Japan, the Radiance HTN Duo, the Global Paradise Registry, which is aiming to enroll up to 3,000 patients, and additional, particularly ISR-driven programs in patients with TKD, heart failure, arrhythmias, which are currently ongoing. And then there are several trials that were performed in the past, like the RadioSign being a completely independent study, Radiance Prefer, Achieve, and Require studies that have finished enrollment in the recent years. A little bit more detailed on the way these sham-controlled trials were designed and actually led to the FDA approval of the technology end of 2023. So that, I think, attests to the robustness of the clinical trial program in patients, as mentioned, off-med and solo, which enrolled patients with office blood pressure of 140/90 on 1 to 2 antihypertensive agents. Patients were then taken off their drugs, and if they still had a daytime ABPM of above 130/85, they were one-to-one randomized to either RDM or sham. So these were completely sham-controlled trials in which both the operator as well as the patient were blinded to the treatment algorithm between procedure and 6 months. A similar protocol was applied in Radiance 2, in which patients were randomized 2-to-1 to either uRDN or sham. And in parallel, the Radiance Trio trial enrolled patients with more, let's say, resistant hypertension, in this case on a standardized triple pill of hydrochlorothiazide, calcium antagonist, and a ARB. And then with that, they still had to have a daytime ABPM of 135/85 or higher, and were then subsequently randomized to either RDM or sham. So all these individual trials met their primary efficacy endpoints, and thereby indeed led to the FDA approval August 2023. So the primary results, and this is important to show you, so in Off-med, so patients taken off their drugs, RDN at 2 months, at which the primary endpoint was evaluated, led to a reduction of 6.3 millimeters of mercury in daytime ABPM. In Radiance 2, a similar effect was actually, so the effect was actually replicated in a larger study, in this case 223 patients enrolled. Again, a 6.3 millimeter delta in ABPM reduction in patients in the uRDN versus sham arm. So as you can see, about 8 millimeters blood pressure reduction between 0 and 2 months in the RDN arm versus approximately 2 millimeters of mercury in the sham arm. In Trio, a very consistent blood pressure lowering effect, also about 8 millimeters of mercury with a slightly higher treatment, or not treatment, a slightly higher drop in blood pressure in the sham arm at 2 months, leading to a delta of 4.5 millimeters of mercury, which was statistically significant. And with that, basically all 3 trials met their primary endpoint. That didn't count just for the primary endpoint being daytime systolic ABPM, but also for ambulatory systolic, home systolic, and office systolic blood pressure reductions, and the delta with respect to sham were very consistent and about 6 to 7 millimeters of mercury. If you look at the percentage of patients that actually got either a 5 or a 10 millimeter decrease in blood pressure, substantially higher number of patients in the RDN as compared to the sham arm. About 50% of patients in the RDN arm had a blood pressure reduction of 10 millimeters of mercury or higher versus only 18% in the sham arm. So if you need to convince your local payers or hospital administrators, these numbers, in my opinion, do make a lot of sense and form a substantial foundation of the evidence that RDN actually works. This is very interesting. I just wanted to briefly show this. This is a sub-analysis of Radiance Trio in which we assessed the effect of ultrasound-based renal denervation as compared to sham in patients, but then in this case adjusted for antihypertensive drug metabolites. Because what we know, and what we've also seen in the trials of competing companies, is that the effect of RDN is strongly impacted by changes in antihypertensive drugs, either prescribed or taken by the patients at baseline and follow-up. So what we saw in Radiance 3 was a 6.9 millimeter of mercury drop or delta in blood pressure in RDN versus sham. But now if you only take the patients in which drug metabolites between baseline and 2 months didn't change, in order to distillate the pure treatment effect of RDN, the adjusted difference, or delta, I should say, in blood pressure increased from 6.9 to 9.3 millimeters of mercury, actually further substantiating the evidence that RDN truly works in a way that is absolutely 24/7. So these are the plots, the waterfall plots that show you that the treatment delta or the blood pressure delta in treatment effect is very consistent throughout a 24-hour period, which is clearly less of a case in patients treated just by pharmacotherapy. The remaining question is always, so which patients to treat? Are the typical responders or no responders? This is the heterogeneity plot based on the pooled analysis of all the Radiance trials, including 506 patients, basically showing you no heterogeneity in the treatment effect in any of the predefined subgroups, focused on either gender, on ethnic background, on GFR, on BMI, the presence of diabetes, etc. Except for the fact that patients with orthostatic hypertension were likely to benefit a little bit more. But again, I think very strong argument that RDN does work, and there are very little subgroups that at least do not seem to benefit. So at this stage, I think little reason to assume that there are particular subgroups that do either better or worse. What about the durability? So a lot of these trials now reach three-year endpoints in which we can see that the blood pressure lowering effect of RDN is very consistent. Obviously in SOLO, in which where drugs were added after 2 months, because these patients again were taken off drugs, increased between 2 and 6 months, but then remained very stable up until 3 years. Whereas in Radiance Trio, in which the antihypertensive medication was at least intended to remain stable, the blood pressure delta between baseline 2 months, 6 months, and 24 months remain very stable. So in these studies, clearly no reason to believe that there is a catch-up in the efficacy of the denervation between 2 months and 2 to 3 years. What about change in drugs? So this obviously is always a question. What happens if you start adding drugs in these patients in these randomized trials? Because this obviously impacts the delta in the blood pressure difference in 6 months. We can see that here in case patients and physicians were still blinded to the initial treatment allocation, that patients in the sham arm got more drugs added to their regimen as compared to patients in the RDN arm, which was statistically significant between 2 and 6 months. So this again attests to the effect of the treatment. Longest durability data is now out there for the ACHIEVE trial, which was the initial trial performed now almost 10 years ago in 8 sites in Europe, in which we can see that the blood pressure lowering effect remains very strong up until 8 years after the procedure in a study that did not show any consistent safety concerns. In line with now also the data confirmed by the Radiance pooled analysis again, including 506 patients, in which within the combined group of the 3 trials, no major safety events were noted per procedural at 30 days and neither at 2 months. So this, I think, is again very strong data supporting the safety of the technology in a program that is robust and is, as of today, still extending with different investigator-sponsored programs, as well as a global registry that is now continuing enrollment within Europe and the United States. So with that, I would like to conclude with the fact that ultrasound-based RDN significantly reduces blood pressure as compared to sham in hypertensive patients. The blood pressure response is very consistent across different severities of hypertension and similar in the presence or absence of medication. RDN is safe with a low to negligible risk of periprocedural and device-related short and long-term complications, and the effect seems to be durable with consistent blood pressure reductions up to 3 years. With that, I would like to thank you and open the presentation for any questions.
Thanks, Hughes. That's great. First question really is about the effect size. So we've focused on the ambulatory blood pressure data there as the primary endpoint. What is the magnitude of impact of an 8 millimeter reduction in the ambulatory blood pressure?
Yeah, so that's the critical question, of course, that at least in the Netherlands, payers consistently have been asking. So what is the impact that we're generating with this 5 or 6 or 7 millimeters of mercury in terms of blood pressure reduction? Basically, there is the reference we have is the large series of hypertension trials that now have been pooled together in several large several large pooled analysis published in the Lancet mainly, in which we learned that a 5 millimeter drop in office-based blood pressure results basically in a 10% reduction in heart clinical events, being either death, stroke, or MI. If you have a 10 millimeter drop in blood pressure, that will result in a 20% reduction of clinical heart events. Obviously, that's extrapolation of data based on device to patients in which, treated with drugs. So in the absence of outcome trials with RDN, I think we have to believe that this is a surrogate endpoint that is also appreciated by European and US administrators to be very valuable and robust as a, let's say, accepted secondary endpoint or surrogate endpoint for clinical effect size.
And one additional effect is we know that in studies the patients usually take their drugs. but after the study, the compliance is much worse. But with RDN, the compliance is 100%.
Yeah, I think that's the always-on idea. Sophie, you're involved in the recent European Society of Cardiology guidelines that approved this procedure for clinical use. You're going to talk about that shortly, but what is the feel for other interventions in terms of effect size? So weight loss, exercise, salt reduction, these are the things that the guidelines strongly support. What sort of effect size are they producing?
Yeah, so the effect size is actually quite similar. So the only problem with lifestyle and weight loss is that it basically never happens. I'm not going to say never, but like there's not too many patients who really like reduce their salt intake if we occasionally do this salt urine spot, and we see that the weight loss is also a problem. But if they do, we see also in the important trials with the GLP-1 analogs that the blood pressure reduces whenever the weight reduces. So if they do it, it's perfect. So I will always tell them, if you lose weight, you will have to take a pill less. But they rarely do it. That's one of the problems. So we had the discussion just earlier. It doesn't mean that you can denervate everybody instead of losing weight, but it's like more a way of like initializing two things at a time. And you want them to lose weight, but you're not going to wait for 5 years until they never lost weight and then do the renal denervation if that's your third pillar after the pharmacological therapy.
Yeah, I mean, you've shown us data there, Just that this procedure produces durable blood pressure lowering, but weight loss programs are not so durable, right? So, this is one of the proven durable interventions that we have in hypertension. As you say, non-adherence gets worse the longer you take antihypertensive drugs, and these lifestyle intervention programs are proven to relapse.
No.
Not that we shouldn't try them, we've got to try these things. But you're confident that this is durable out to the medium term?
Based on the data we have, there does not seem to be a catch-up in the blood pressure reduction that is initially achieved. So that's what we know. I mean, there are no drug trials with 5 to 10 years follow-up, so it's also very difficult to compare, right? There are no real-world large-scale registries capturing clinical events in hypertensive patients treated with a ARB or with hydrochlorothiazide. So the persistent question in providing outcome data and long-term follow-up data on a blood pressure reducing technique or pill is currently lacking. I think we have to work with what we have and accept that a blood pressure lowering at the short term and long term has clinical impact in a population in which we know that non-adherence amounts up to 50%. And we see it now if we screen patients for RDN, referred and worked up by vascular internists, by nephrologists, perfect workup, 3-4 drugs. And if we do drug metabolite testing, which we now routinely do, 30 to 50% of the patients are non-compliant. And that to me is striking.
Yeah, they're sending us a message, aren't they? Okay, thanks very much, Just. Great. So next up is Sophie Bruce. So Sophie's a hypertension specialist involved in the recent ESC guidelines, and she's going to talk about how to apply those guidelines to the patients that you see.
Good afternoon, everybody. Thank you for the invitation. So applying the new guidelines. These are the new guidelines, as you're all aware of. I brought a patient for you, but first to remind you that we simplified the blood pressure categories, that we kept the blood pressure as hypertensive above 140/90, but that we speak of non-elevated blood pressure below 120/70, and that we speak of the elevated group, and the elevated group is the group actually, just to go pretty quickly, whenever there's high risk or very high risk, we absolutely want to start treating those patients earlier and not waiting until they are hypertensive. So that's also why we changed the title of the guidelines into not only the management of hypertension, but also management of hypertension and elevated blood pressure. So this is very important to take away, and this is very important because these are especially those patients with elevated blood pressure and high risk that will benefit most, and where it will be cost effective to do anything about the blood pressure. I brought you a case. It's a woman. She's 67 years old, and she's referred for a cardiac checkup. She just wanted to know how everything was doing because she remembered that her father had some problems with her heart. She asked her siblings, and apparently he had coronary bypass graft when he was 58. So she comes and she tells me she's hypertensive and also wants a checkup therefore. She recently had a TIA. She has hypertension. She takes treatment for dyslipidemia. She has pre-hypertension, has a BMI of 29, has never smoked, and has a personal history, as I just said, of a TIA, and her brother recently had a PCI. She's currently taking perindopril amlodipine that has been increased until a dose of 10 milligrams once daily. She's taking rosuvastatin, 20 milligram, as you've seen at the LDL levels. She's currently taking it, and she got aspirin. She says that since a week, she has slightly swollen ankles. And when we examine her, we measure the blood pressure, obviously, a couple times. And we have blood pressures that are clearly increased at the office measurements. And she had her document with her with the home blood pressure measurements that were taken correctly. And those really are almost in the same range. We have a normal ECG and we have normal lab tests further on, except the hemoglobin A1C, as you've seen. So the algorithm that is proposed in the guidelines, I will go through it and zoom in, is of course that we start with low-dose double combination therapy, a RAS blocker, plus a CCB, plus a thiazide or a thiazide-like diuretic. Then, and that's very important, we have the blood pressure checked again in 1 to 3 months, and preferably 1 month, because, as I said earlier today, it's important whenever we start treating that we just proceed. The blood pressure is too high, we treat it, we check, we increase the dose, we check, and we continue. And we don't let months or years go over it. Whenever the blood pressure is then still too high, we increase the dose, or we go to low-dose triple combination therapy, or in some patients, it's possible that if there are some compelling indications, we already add a beta blocker. But to stick with one pill, we have the low-dose triple combination therapy, and that is what I gave to this lady. I reduced the dose of amlodipine because I was quite sure, coming from a lower dose, that this was what has been the reason for the swollen ankles. So the question is, how should the blood pressure be lowered further? I see her back 1 month later. BMI is stable, although, of course, I spoke to her about doing more, moving more and on eating healthier. She didn't walk more, but she tried to improve her dietary choices and to reduce her salt intake. So when we do the office and the home blood pressure measurement, we still have values, sorry, there's a one lacking, of 140 over 145, over 90 to 105 millimeters of mercury, so still pretty high 1 month later. On, as I just said, triple combination therapy in a single pill. And this is very important, as we just heard. There's a lot of patients who are not taking medication, and one extra medication is for them already a big burden, and they usually refuse, and if they don't refuse it upfront, they will just not take it most of the time. So what do the guidelines say? Then we speak of apparent resistant hypertension because we don't know yet. As said, in Belgium, for example, we cannot dose urine medication, so we don't know if she's taking the medication. I do think so. And then we have the suggestion to refer to hypertension clinic if that's not where she is yet. Test for adherence, as I said, something we cannot do in Belgium. And then we can maybe add spironolactone. But, as I just said, polypharmacy leads to non-adherence, and maybe spironolactone is an option, but adding even more medication will most likely not help us. Of course, talking about catheter-based renal denervation, we always have at this point the discussion with the patient that there can be some extra medication given, but that there is also a procedure that really reduces the overactivity in the renal nerves. And I don't need to go over this again because Joost just showed that us that renal denervation works. And we recently had our 10-year data in our center, and we see exactly the same result. Of course, it's non-randomized, but we see a nice decrease in blood pressure over time. So coming from the 2018 guidelines and going over to the 2024 guidelines, in the meantime, we published a consensus statement from the ESC highlighting how to do the renal denervation, who should be in your multidisciplinary team. And then we come to the 24 guidelines, where we now don't have any longer renal denervation only should be done in trials, as it was written in the 2018 guidelines, but now it's a valid option for certain patients. And what is the valid option for those patients? There's actually two groups that we need to look at, and there's the group of resistant hypertension, and the group of resistant hypertension is small because that means that you have true resistant hypertension, but this is a group with a major unmet clinical need, and there it's very cost effective to do renal denervation. So certainly for those patients with higher cardiovascular risk, it's absolutely a good idea of thinking about renal denervation. But the other group is a group of uncontrolled hypertension. That are the patients that are non-adherent or intolerant. We all have those patients. For example, she was only intolerant to amlodipine 10 milligrams, but we have patients who come with whole lists of all the medication they've taken and they cannot tolerate. Whether we believe it or not, all the side effects they are telling us, they do not tolerate it. If we force it upon them, they will not take it. So multiple blood pressure medication will not increase or cannot be increased in these patients. And in these patients, the blood pressure remains high, so they have a high cardiovascular risk. And if they then say that they have a preference to undergo renal denervation, the guidelines do back this up as a valid option. So this brings us to the treatment options. As I said earlier, it's very important that we move quick with this treatment. Patient has an elevated blood pressure. We say what needs to be done on lifestyle. We initiate almost always therapy. We initiate always low-dose double combination. We up-titrate. And then we come to the point where you have a maximally tolerated triple combination therapy. And then there's a few options. You can discuss the fact that there's spironolactone, which is a potent drug to decrease blood pressure, but there's quite some patients who have side effects, who develop side effects, or who had side effects in the past. There's beta blockers, where we prefer to use the vasodilating beta blockers with sometimes variable efficacy and also very important side effects, especially if the doses are high. I will always tell my students at the university that this is not a first-line therapy, as they are still learning in other courses. This is absolutely not done, so the side effects can be very important, and especially in younger patients. And then, of course, we have the option of renal denervation. So if the drugs are not tolerated, are not taken, of course, renal denervation is always on effect. We can do this in high cardiovascular risk patients and reduce their cardiovascular risk. But, of course, it's a question of patient preference. So you have to have this discussion. And some patients will be a little reluctant and have to think it over and say, like, I'm going to try one more drug and I'll come back. But then you already have the discussion before. But there's a lot of patients who rather have once, of course, an intervention than take another drug and are really keen on having a small, short intervention that they only have to do once. So this is really about patient preference and the shared risk-benefit discussion that we need to have and move on. But what I really want to say also with this slide is that we need to have this discussion early on. It doesn't needs to be that the patient is immediately planned for renal denervation, but there needs to be the discussion. They need to know that there are options, that they are seeing a physician who has multiple options, that their blood pressure will be controlled almost always at the end of the trajectory, and that makes them more confident and also more likely to then continue taking the drugs they are taking. So very important, before we get to all to this, are the key messages that we, of course, would have to make sure that we have the blood pressure correctly measured and that we always have out-of-office blood pressure measurement. We never send someone to renal denervation without ABPM, so that's very important. we need to highlight the lifestyle, but as I just said before, reducing the salt is for many patients also very difficult, reducing their weight. We need to emphasize it, and I'm as a rehabilitation cardiologist, I'm really in favor of them doing something on their lifestyle, and if they do it, it has effect, but there's not the majority doing something about it. Then we absolutely need to use the single pill combination therapy up to triple combination. We target the blood pressure to 120 over 129. That's very clearly shown to be beneficial. And then we have follow-up and communication that is key to make sure that the patient is followed up regularly and is communicated what are the next options. And then if we get into the option of renal denervation, we can clearly tell the patients that there are no safety concerns or almost no safety concerns, that it clearly reduces blood pressure, not in 100%, but that's the same when adding medication. Not in 100% of the patient, this will reduce blood pressure. It's good for resistant uncontrolled hypertension, as I explained to you. And there's need to have this discussed in a multidisciplinary hypertension team after a shared decision-making also with the patient, and it's open for discussion, although we said in the consensus statement who should be or should be best in this multidisciplinary team. It also depends on the hospital situation, whom you are discussing before sending the patient for renal denervation. But I think with this rapid, quick and efficacious workup, we would get more patients into targets. And with that, I'm finishing in time. And I have any questions from the floor.
Thank you, Sophie. You made a very important point, which is the difference in between resistant hypertension. All the initial trials and the indications to use the therapy were focused on resistance, and you made it very clear, resistance is very infrequent. So if we look for resistant patients, you will have very few patients. On the other side, the uncontrolled patients are very, very frequent. So if we look for the uncontrolled, we will have many patients. And the guidelines considered both options. The point is, the uncontrolled is normally a patient who is not behaving well, as the case you showed. I mean, eating too salty, not moving, overweight, not a healthy lifestyle. And the patient comes and says, no, I don't want to take all these pills. I want to have renal denervation. So this comes into patient's preference. How do we deal with that? I mean, how permissive are we when we say, okay, we will do it despite the fact that you don't take the pill? So this is very difficult. I'd like to know, how do you manage these kind of difficult patients?
I think it's very similar to how everything is done with GLP-1 analogs. The other day at the university, one of my students said in the hypertension course, yeah, but if she's obese, why don't you give her GLP-1 analogs? And I was talking about a case of a 23-year-old student. I was like, not going to give this guy a GLP-1 analog. Like, he just gained like 10 kilos by going to university and eating like a beep. So that's absolutely no, I'm not going to give that to them. So which would be actually almost the same. I'm not going to do renal denervation in this 23-year-old student who just gained like 10 kilos over less than 5 years. So of course, then you have this discussion and you say like, okay, you know what you need to do, you're eating unhealthy, blah, 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 all these things. But these patients are not the majority that we see. We usually see them when they're 40, 50, 60, and we're mostly not the first ones seeing them, not the first ones telling them that this needs to be done. So it's the same as in the previous years, whenever a young woman had higher blood pressure, physicians would say like, oh, it's okay, she's still young, we'll deal with it. No, because then we end up 20 years later with the first TIA, with a stroke, with whatever LVH problem. So there's a lot of problems if we don't do anything about it. So I think there's a small proportion where we can wait, but I think there's a large proportion where we should like limit us in time and be like, okay, I can give you a little bit more time. If you prefer medication first, fine, we can give you an extra pill, but I think you always need to move forward, and that's important, what I wanted to say with this presentation in the case.
Sophie, there's people here who may not see as much hypertension as you. They have hypertension patients in their clinics, though. What tests do they need to do before considering renal denervation?
So first of all, as I explicitly said, like we always need an ambulatory 24-hour blood pressure measurement. So testing to make absolutely sure that the patient is is having high blood pressure. What I usually do, because it's something, as I said, we cannot test the urine on medication. I usually do observed pill intake. So I ask my nurses I ask the patients to bring the medication to the hospital and to take the medication in front of the nurse and then have the 24-hour blood pressure measurement, just to make sure that they are taking it. It doesn't mean when they come back and I see the blood pressure is perfect, I need to have the discussion on why aren't you taking it, blah, 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 because now your blood pressure is controlled. That's on one side. And it doesn't mean that I'm not going to denervate them, because maybe then the discussion comes up on, I'm not tolerating this, I don't want to take this, and it still can lead to an uncontrolled case that is denervated. If you're talking about secondary hypertension, if that was the second part of the question, so we always check for renal artery problems, FMD, renal artery stenosis. We usually do a hormonal bilan in everyone. We don't do the metanephrines in the 24-hour collection if there is no anamnestic clue for it, but we always ask also for people if there are arguments for OSAS, we send them for a polysomnography. But the problem there also is the same with obesity clinic, that it takes in Belgium now 6 months to wait for it, and that we also know that it's not going to decrease or get their blood pressure perfectly controlled whenever that is checked. So that is, I think, the things that we regularly test.
And sleep apnea are good candidates, right? So sleep apnea patients are good candidates for denervation. Rule out primary aldosteronism with an aldosterone-renin ratio. Don't worry about urinary metadrenalins and pheochromocytoma. It's never that.
No.
And just make sure they haven't got FMD or renal artery stenosis.
Yeah, I think that's the most important.
Yeah.
I have a question. So the patients with advanced kidney disease are often a problem. They have high blood pressure and they don't tolerate the drugs. They have side effects, they have interactions. So how do you deal with these patients, and is renal denervation a good option in someone with a GFR of 20?
Yeah, so the thing is, in the guidelines and in most of the guidelines, it's written that it shouldn't be performed routinely below a GFR of 40, but we sometimes do it. Whenever we have the multidisciplinary team with the nephrologist, as I said, it's not always the same people who attend, but whenever it's concerning a CKD patient, we have the meeting with the nephrologist, or we make sure that he's there. But we had some patient with chronic kidney disease, and we have the impression, as does the science, that it also decreases the decline for chronic kidney disease. So, but it's in our center we did just a few up until now, but we're not excluding them completely.
Why is that this came out to be a formal contraindications? I mean, it's a class 3 saying you shouldn't do it; it might be harmful. And you said there is no evidence of that. So how this came out in the guidelines?
Because it comes from the trials. In all the trials, it was people with CKD below 40 of GFR were excluded. So there's just no evidence or not enough evidence. So that's how it came into all those guidelines that below 40 you shouldn't do it. But people have been doing it, and it seems.
Flavio's got a paper coming out on this.
Yeah, voilà.
So we all look forward to reading it.
Outside the guidance indicates, because it's true there is no evidence, but it's also true that there is no evidence of harm.
Yes.
So I agree without an indication, but I do not agree with the contraindication, because it's totally different. And patients with impaired renal function are those that theoretically will benefit most because of the overexpression of the adrenergic system. So if there is no harm, you should really consider them. And of course, you have to work together with your nephrologist, because they know much more than we do, and they will teach you a lot of things that will convince you to treat these patients.
Nephrologists will start out very uncertain when you start your programs, but as soon as you get going and they see the blood pressure effect and that it's safe, they're all in. They throw patients at you. They're really good.
Just for you to know, the Italian Society of Nephrology, I don't know if there is some of my nephrologist colleagues here, I mean, they have just prepared the consensus document that, despite the guidelines that we just released, they do recommend the use of renal denervation in patients.
Yeah.
Roland, you will be very proud of your Italian colleagues. Roland is a very prestigious nephrologist from Germany, and he knows a lot about this.
Yeah, may I comment on that? I think safety is a major concern. And I had the privilege, together with Marco Schleich, to analyze all data, which has been done with radio frequency ultrasound, more than 3,000 people. And we had also CKD stage 3A, but also CKD stage 3B. It appears the GFR remains on the same level, a little bit lower, but not less than what you expect just by aging. So it is a safe issue. This is the most important thing. And by the way, tomorrow I will present some data with the ultrasound renal denervation, where we did take the radiance program and looked at CKD patient and did a propensity score matching. So tomorrow we will have the results.
Great.
Okay, excellent. All right, thanks, Sophie. So Stefan Togwell is going to talk about setting up a program, maybe throw in a little bit about the procedure.
Yes, all right. All right, thanks for having me. Yeah, how to set up a program. These are my disclosures. So I think the first step is written on the top. We are interventional cardiologists, but we have to become interested in hypertension. And that is not only renal denervation, that's also drug treatment and screening and collaboration and so on. So I think that's the most important. And then, of course, we want to have a dedicated team of experts in hypertension, which is going to be interdisciplinary. We already heard that. And then we have to talk about the disease, because let's be honest, how many symposia have you attended about hypercholesterolemia and how many about hypertension? And I'm sure you have attended many more talks about high cholesterol. And the reason is quite obvious, because the companies were just not so interested. And this has changed now. And it may be also, it's going to change in future, because we have new drugs, new antibodies, RNA silencer, and so on. And then, of course, you perform renal denervation with a dedicated team. So this slide is from a study from the Bill and Melinda Gates Foundation. And I'm not sure if you were aware that high systolic blood pressure is the single most cause of death worldwide, followed by smoking, nutrition, air pollution, diabetes, obesity, and cholesterol at the end. Now in men, to be fair, tobacco is still number one, followed by high blood pressure, but globally it's high blood pressure is the number one factor causing most deaths globally. I didn't know that. And of course, what we want to prevent is end organ damage by lowering blood pressure. And end organ damage is a continuous process, mostly hypertensive heart disease, stiffness of the arteries, atherosclerosis, hypertensive kidney disease, hypertensive retinopathy, and stroke. But we want to treat our patients early and correct. We want to achieve the targets and prevent these catastrophes. And this slide, we talked about it before, shows the effect of blood pressure lowering on these outcomes. And this is really striking. So just 10 millimeters of mercury results in a massive decrease in stroke and a massive decrease in heart failure with preserved ejection fraction, maybe even reduced ejection fraction. So we can prevent events and we can help our patients here. So these two are running my hypertension clinic, Renate Schönenberger. She's a clinical cardiologist, and Franz Messerli is a very experienced expert in hypertension who worked in the US for a long time, and now just for fun he's coming to Lucerne a few days per month. And then, of course, we have a team of interventional cardiologists as well, but it's really in the hand of clinical cardiologists. And why is that important? So this is a case of a 80-year-old man, and this actually just happened 3 weeks ago, and I didn't make this up. This is a real patient. So he has so-called malignant hypertension, and university hospital in Switzerland already recommended renal denervation, but the patient didn't want to have that. So he came actually for a fourth opinion. He came to Lucerne, and these were his drugs. So he's on amlodipine and Entresto even, metoprolol, spironolactone, indapamide, furosemide, and ebrantil. And this is his 24-hour blood pressure. So yes, about 180 over 120 millimeters of mercury. And if you followed the talks, you already know what the problem of this patient is. He's, by the way, not obese. So in urinalysis, there was no detection of amlodipine, valsartan, sacubitril, metoprolol, spironolactone, indapamide, furosemide, and ebrantil. So we stopped all drugs and told him, look, just take one pill and you will be fine. So we gave him a very potent antihypertensive drugs, which is actually my personal favorite, acylsartan, chlortalidone, edarbichlor, and blood pressure was in target range, just like that. So why ultrasound? Renal denervation, we had to make a decision. We didn't want to have two systems. So first of all, we heard about the clinical evidence, which I think is really good. We have a lot of sham trials. The procedure time is quite short, so you can do the procedure maybe in 45 minutes, I would say. Also, it's possible to do it in conscious sedation. We usually give midazolam and fentanyl, and patient can be an outpatient. It doesn't need to be hospitalized. So these are all important aspects. That when you do the denervation, it hurts the patient for about 2 seconds, so quite short. And usually, if you give enough midazolam and fentanyl, he will not remember. So these are all advantages. I'll show you a patient that we actually did denervate. The patient is a 73-year-old man. He has HFrEF with a poor ejection fraction. I show you the echo. He has a complete left bundle with a QRS of 180, and he has uncontrolled hypertension. And he is on the 4 drugs that you usually give for HFrEF, so the Magnificent 4. But he doesn't tolerate them because he gets migraine attacks. And so he's very reluctant to take them. And this is his echo. You can see the rocking with the dysynchrony. QRS is 180. Ejection fraction is super poor, and these are his blood pressure measurements, which he takes at home. And you can see at Christmas or around Christmas last year, he has also migraine attacks, and the blood pressure is 180. So he's not doing well. So we did denervate this patient, and of course we implant also a CRT, which is a very good indication here. And then the patient came back and he said, you know what, I'm feeling so much better. I still have migraine, so I still cannot take my drugs every day. But these are now his blood pressure measurements and his echo. And again, I didn't make this up. This is a real case. For me, this was almost a miracle. I told the patient, this is a miracle. Look at his ejection fraction, which is almost normal now. And look at his blood pressure, which is really amazing. And he still doesn't take the drugs always, so I cannot rule out that he takes it a little bit more now. But this improvement in blood pressure and improvement in ejection fraction is just amazing. So the take-home messages, I think, as I said, you have to build a team. You have to put the spotlight a little bit on hypertension. For example, what we do, we have now rounds for GPs, for referring physicians. We do them 3 times per year in the evening, where people can also bring their patients and discuss. We also have one symposium, which is going to be in September this year, where we talk like 4 or 5 hours just about hypertension. You can talk about new variables and so on. You can mix it up a little bit. And but I think it's important that you as clinic directors organize this, because, and then also we find sponsors for the meeting. This is possible, but I think that at the moment the pharma industry is not so active in this field, at least in Switzerland. So the initiative has to come from you. So this is very important. And then we already talked about the interdisciplinary aspect. So hypertension is super common in older patients, and we mainly treat older patients. And a lot of disciplines are involved. I put some here, of course, cardiologists, but also nephrologists, angiologists, endocrinologists, general internal medicine specialists, and pneumologists because of the sleep apnea, which also causes hypertension. So it's very good if you can collaborate with these clinics. If you meet, we also invite them to the symposium. They also have main speakers, nephrologists, and so on. So we really work together, and then you get more referrals as well. And then you perform the procedure with a dedicated team. I think here you really should have the intention to have zero complications with these procedures, no excess complications, or discharge, early ambulation, and so on and so forth. And then you follow up your patients, of course, as well. Thank you very much.
Thanks, Stefan. Can you just take 30 seconds, just talk through the steps of actually doing the case? So how do you get access? What catheters do you use? French size, anticoagulation, that sort of thing? Yes.
So we go, of course, femoral. You could go radial, but we go femoral. We take a short 6 French guide catheter. We give 5,000 units of heparin. And then we do the ablations or denervations from distal to proximal, usually about 3 per side. Sometimes you need different balloons, so you have to exchange the balloons. You start with a smaller balloon in the periphery, and then with a larger proximal. And the procedure takes about, I would say, 45 minutes, maybe. Maybe you can be quicker. If you can do everything with one balloon and you're very quick finding the arteries, you can do 30 minutes. But it's a quite quick procedure. Then we watch the patient outside until the drugs are weaned off. And then the patient goes to a short stay unit and is discharged maybe 4 or 5 hours after the procedure home. And that's it. And then, of course, before we do 24-hour blood pressure, then a few months after a procedure, we do a 24-hour blood pressure to document the efficacy of the procedure.
And routine use of femoral closure devices? Or do you
I
just
think
press?
it's a bit operator preference, but I use, sometimes I think we also do manual compression in someone who is not obese, but we may use a pro style as well. I think this is actually, I actually don't recall last time what I did, but I think you can do both. It's just, it's not a lot of heparin is needed.
Usually an angioseal man myself.
Yeah, or angioseal.
Okay, we've got 10 minutes for discussion. Does anyone have any questions? If they have, there's a microphone there. Do you want to just go to the microphone and just ask the question?
Thank you for your informative speech. When do you expect the effective of this procedure and the long-term effect of this such procedure? How we can expect that?
Sorry, the long-term effect on?
Of this procedure on hypertension.
Okay, so
do you expect that hypertension go higher after a while, 6 months, 1 year, or such?
Yeah, I mean, I think in theory, of course, you could repeat the procedure if the patient has recurrent hypertension, but usually the effect is very long-lasting, and also with the ultrasound denervation, you create a really good scar around the artery and a real good effect. So usually we don't expect the effect to wean off over time, and you have to wait a few months to get the full result of the procedure. So it's not that the patient on the next day has a much lower blood pressure. This is also important to tell the patient. And then, of course, there are these other effects, and we haven't talked about this, but I think one group of patients that is actually really good for this procedure is patients that come to the emergency with decompensated hypertension or with emergency hypertension crisis, so blood pressure 240 over 100, and these patients, they have already shown that they are not really well controlled, And these are good candidates. So maybe we can reduce then not only blood pressure, but clinical endpoints such as admission to hospital or emergency or decompensation for heart failure or even new onset atrial fibrillation. There is more studies, of course, coming, of course. For the young patients? No, for elderly, above 75 years old. For 75? For elderly? Yeah, I think there is no problem with that.
Stefan, when you come join us, we'll have a panel discussion. So,
sure.
Thanks very much. Okay, Juice, we'll just emphasize that longevity thing. You referred to it in the beginning. Is there any reason to believe that this effect will fail and blood pressure will come back over time? And tell us about the data you've published from your center.
So there has been some data on nerve regrowth in animal models. So that's what we know. So conceptually, that could be an issue. That is conceptually, in my opinion, also directly related to the way you do denervation. If you do a partial denervation with a technology that may be less efficacious or not circumferential or with less proper wall contact, etc., and you generate an ablation area that is perhaps a bit less consistent, it may conceptually be conceivable that these nerves regrow. In patients in which you really achieve a complete 360-degree denervation as confirmed by pathology, the likelihood that these nerves will re-innervate if you do the ablation at 2 to 3 sections along the artery, in my opinion, is very low. And that is substantiated by the evidence that we have in human actually not showing any signs of catch up in terms of blood pressure increases at some point. That said, we all know, and that's also what Sophie very nicely illustrated, blood pressure is dynamic throughout a circadian rhythm. And if at some point the patient has life stressors or gains 10 kilograms in weight or stops taking his medication, blood pressure will change. So I think it will be very difficult to provide robust evidence showing us the exact durability of the pure treatment effect of RDN. So that, I think, is something we have to let go at some point and trust on the at least short-term data that we have showing it's efficacious, and the absence of data showing that, let's say, after 1, 2, 3, or maybe after 8 years, you see blood pressure in these patients go up again. So I think those two things make me at least very confident that this therapy is durable.
Yeah, I've done some animal work, and the downstream nerve becomes effectively phagocytosed. It disintegrates. So even if you were able to jump the denervation, you're jumping from an upstream nerve body to a downstream destroyed nerve. So I think it's highly unlikely it's going to come back, and the human data seems to support that. Let's go to how you sedate them, because it's a really important thing for operators here. So Flavio, tell us how you manage pain during the procedure.
Well, you all must know that the procedure is very painful. I mean, the perception of pain is very subjective. Some people complain a lot, others resist, but in general, no one should have a bad memory of that. And so it's very important that the patient is well sedated. Normally, we go with a very strong opioid doses and fentanyl. And we don't have the privilege of working with an anesthesiologist in the room. The procedure takes in and out, it's 1 hour. In 1 hour, we do a TAVI procedure, or an ablation of the AFib. So we don't have this privilege. So we manage this by our own as interventional cardiologists and our nurses. But it's very important that you use drugs that causes also retrograde amnesia. Because sometimes the patient have pain, but then he does not remember. And this is very important, so he cannot tell others that the procedure is painful. That's very important. And the other reason why he must be very sedated is that he must remain in the bed without moving, because movements may prevent the good contact of the devices, either the ultrasound or the radio frequency with the artery wall, and the system will stop. So the procedure gets long.
With the ultrasound device, we're talking about 7 seconds, 6 times, and the energy ramps up, so it takes a few seconds for the pain to kick in. So maybe 28 seconds of pain. I usually describe it to them as less painful than a trip to the dentist, and it's actually a good contextualization.
Brutal.
Yeah, it is painful.
I hold my finger once on the device, completely naive. I will not do it again. It's such a it's such an intense pain. I've never felt that, because you can tell it's really under the tissue. It's under the skin, and this is how it works, right? It cools the surface, the vessel wall, but then it really burns everything else. So I think I fully agree with Flavio that you have to sedate the patient. So we give a lot of midazolam. So we give like 4 or 5, not just 1 milligram. We give 4 or 5, and then 100 of fentanyl. And the patient is usually sleeping, but then for the last 2 seconds of the denervation, they almost all they say or something. So it does hurt.
Yeah. I mean, I've never had a patient say they wish they hadn't had it because of it. It's always manageable.
Yeah. I think that is critical. Proper explanation up front and saying it specifically with this type of procedure, 6 seconds, it's not long. And we rarely, if never, have patients that really complain it's too painful or inhuman or whatever. So, of course, it's subjective, but in general, our impression now is that most patients tolerate it without any issues.
Yeah.
You say Dutch patients. That may change.
In a city in which 60 to
patients.
80% of the inhabitants is coming from all over the place, so it's but they're Dutch, yes.
Yeah. And so, very briefly, Sophie, in 5 years' time, how many patients do you think will be having renal denervation per year in your center?
That's a good question. In 5 years from now, 10 a month.
10 a month. So 100 and something. So that's a fairly conservative practice, right?
Yeah, that's a conservative guess.
Yeah. So I think if you're interested in getting involved, you're not going to be doing 5,000 procedures a year, but a good program, it's 30 to 150 a year, depending upon the scale of your referral base. Do it properly, do it responsibly. We don't want any complications. We don't want weird cases being done strangely. Just get started, and you'll see that some of these patients have spectacular responses. Some have no response. 1 in 4 have no response. But when you meet a patient who's got no logical explanation for how their blood pressures come down, other than the effectiveness of this procedure, it creates a ripple of referrals. And then you'll get referrals from that source for the rest of your career. All right, I think our time's up. So thank you very much to the panel. Thank you for coming.